The primary benefit of visual electrophysiology is that it gives us additional information. So specific to glaucoma, I think the biggest value is those patients early in the disease course.
Well, as we know, electrophysiology has been around a long time, so the system that we've been using, which is the new Diopsys Nova system, is sort of a new face on old technology. It's really one of the only objective functional tests there is in ophthalmology.
We all were in residency, we sort of poo-pooed it, and that was really set aside for a lot of folks that had esoteric diseases, retinal dystrophies, but now with most of us doing a lot of glaucoma screenings, glaucoma suspects, and the fact that we have so many modalities to treat glaucoma in terms of MIGs, in terms of drops, combination therapies, lasers, it's more important for us to diagnose functional damage much earlier and treat the patient earlier to help alter the disease curve is what we seek, and electrophysiology really fits that bill.
Well, in my world, it's mostly patients that are cataracts, glaucoma, macular degeneration, retinal pathology. So it's not your typical assumption of what electrophysiology would be. And I think that's the beauty of the Diopsys Nova system, is it's allowing users and doctors like me to be able to take this technology and actually elucidate a lot of these problems in our practice.
We are using it in a variety of cases of patients with glaucoma suspects, patients with visual fields where the visual field doesn't actually quite make sense. We're using it in patients with low tension glaucoma, where really it's difficult to ascertain what's happening in these patients because they have a quote-unquote normal pressure. They may have a totally normal visual field, but they have a very abnormal optic disc. So in those patients, this electrophysiologic testing is, I think, of great importance and of great help. It's another tool in the toolbox, basically.
And there's no doubt for our glaucoma practice, which is 42% of my practice, it's had an immense impact on making diagnoses earlier, helping chart prognosis, how the patient reacts to treatment, and also when you're on the borderline of thinking about a patient who is glaucoma suspect, ocular hypertension, how aggressively to treat their disease.
Well, I've had several patients that have come in that, I've been watching. Their pressures have been in the low 20s. I had one in particular that I'd watched for 2 years. One eye was 22 on the pressure, the other one was 25. All of my testing was fine. And once we received the Diopsys Nova machine, we went ahead and ran it on the patient, and lo and behold, the eye that had the 25 was showing some attenuation of the peak and a delay on the VEP. So we knew something was probably going on there. So we went ahead and initiated treatment with the patient, and over the next 6 months, we watched the waveforms come back to normal.
The holy grail for glaucoma and or all forms of progressive optic neuropathy is to be able to nail down, well, is the problem in the retina or is the problem in the visual pathway behind the eye? And now there's a way of doing this and finding this out that we didn't really have before. So it has helped us tremendously because we find now that there are patients all in the conglomerate of presumed glaucoma coming in, and some of them have a predominantly retinal problem that shows up on the electroretinogram. Some of them have a predominantly visual pathway problem that shows up on the visual evoked potential. Some have both. Now we can segregate our patients into subgroups. And of course, the treatment that's beneficial for the patient who has a retinal-based pathology may turn out to be different from the best treatment for a patient who's got something on the way to the occipital cortex or the lateral geniculate. So we feel that not only is it helping us understand today's patient, but it's going to help us develop new therapies that are going to save a lot of morbidity and save a lot of sight in the long run, in our own lifetime.
So of course, we're deciding whether or not to treat or not treat them based on the really using this information in conjunction with the other testing that we have. And if this VEP, or primarily in glaucoma, the pattern electroretinogram, is abnormal or suggests that there's poor waveform or reduced magnitude or amplitude, it indicates that there's reduction in the retinal ganglion cells, or these cells are sick or dying. So we're going to be much more aggressive in treating those patients.
So the Diopsys Nova Vision system has also played a role in helping us determine how well a patient is responding to therapy. Because as we know, when we look at retinal ganglion cell function, There's really multiple phases that the cells are going through in glaucoma. So you have a healthy, normal function population, and you have the kind of dying and not working so well population, and their fate is kind of sealed. But then you have this borderline population where they're starting to be under stress, and they really could go either way. And we see this when we lower eye pressure enough or treat these patients appropriately, we can see improvement in function. And with this technology, the NovaVision system technology, it's very sensitive, and we can see a reversal of an effect, where when we measure structural tests, say with OCT, we may not see that, but the functional tests can improve with an improvement of the environment for the retinal ganglion cells. So it's a nice measure when did I lower the eye pressure enough? And this can also be an indication, I lowered it according to treatment guidelines and I think it's enough, but I'm worried about this patient. If we see reversal in this functional test, it gives us more confidence that we did the right thing, or if we don't see any changes, maybe we need to be a little bit more aggressive.
Not only would I recommend it, I have recommended it. I've probably encouraged many of my colleagues that are interested in glaucoma and retinal diseases to encourage going beyond the traditional tests and pursue obtaining the ERG VEP Diopsys system in their practice.
Yes, I've done so already. The Diopsys company has embraced the whole field in a way which is very proactive. And I might add, they're very good at helping out, not just in the early phase after you bought the machine, but on the long term.
I would recommend it to any of my colleagues who have the appropriate population. So I think that's as simple as you treat a fair number of glaucoma patients, or you have patients with some neurologic conditions, or you have amblyopic patients. I think all these clinical situations are kind of easy entry points. If you have a practice with no pathology, I guess maybe you don't need it.
Actually, we have recommended it to a lot of our colleagues, and because I think, again, it's another tool in the toolbox. And we think we understand a lot of diseases and we think we know what we're doing, but this test actually makes us gives us an objective standard or objective functional approach to these patients, and I think that that's a huge benefit.